history to remember what a Trojan horse was.
Awesome. So we are live. And we're going to start in right at 7:30. So
do you want us to go to Facebook or stay here?
If you're cool to go to Facebook, that's great. But if you want to stay here, that's fine too. Paul Newman is going to be our Facebook moderator. So if you have questions, you can type that in the Facebook comments and Paul will read them.
Do you want me? I could also place them in the chat if you want. The questions, cut and paste them into the chat.
So we're definitely live. Want to do mission statement?
So you can just do it the way, just to do it from Facebook the way we've done it in the past, and I'll do the chat on Zoom.
For me, if you can put them in the chat on Zoom, that would be helpful because I'm not going to be able to be on both.
Yeah, what Paul would do is he would read them to you.
Yeah, okay.
So, all right, everybody. So it is 7:30. Welcome. My name is Erica Ferriston. I am the Director of Healthcare for All Los Angeles, along with Maureen Cruz. Maureen, you want to wave? And I am co-chair along with Betty Dumas Toto. I think her video is off, but she's here with us. Anyway, we like to start off with a land acknowledgement. This is borrowed with permission from White People for Black Lives. Big shout out to them. And so Healthcare for All Los Angeles acknowledges the Tongva peoples as the traditional caretakers of the land we currently reside on. That is the Los Angeles Basin and Southern Channel Islands. We seek to honor the land and the courageous people who have been its stewards, modeling a tradition of resistance seeking liberation. We pay our respects to ancestors, elders, and relations past, present, and emerging. If you are outside the greater Los Angeles area, you can find out whose land you are on at native-land.ca. And so who are we? Well, we're Healthcare for All Los Angeles. We are a local chapter of Healthcare for All California, which is a statewide nonprofit, nonpartisan organization. Our mission is to achieve a universal healthcare system through single-payer public financing with the goal that all California residents have comprehensive, high-quality healthcare. So, as Betty Dumas Toto likes to say, we are single-minded for single-payer, and we are so fortunate to have a single-payer bill, AB 1400, the Guaranteed Healthcare for All Act, also known as CalCare, which you see behind me and behind some of us up here on Zoom, behind Maureen and Paul. So tonight's format, we have a speaker here, Stephen Kemble. We're going to listen to our speaker, and then we'll have Q&A at the end. For those of you joining us on Facebook, drop your questions in the Facebook chat, and Paul Newman, Paul, if you want to raise your hand, he will go ahead and ask your question for you. He will state your name and ask your question. And for those of you on Zoom, drop your questions in the chat and I will ask your questions. Paul and I will alternate between. So everyone on Zoom who's not a speaker, please mute yourself. And with that, I will turn it over to Maureen Cruz to introduce our speaker.
Hello, it's my great pleasure to be able to introduce Dr. Stephen Kemble. I first became aware of Dr. Kemble through the One Payer States Policy Committee, of which he is, I believe, a co-chair, but definitely a member who is always writing and contributing. He is a highly regarded expert on many aspects of single payer systems. Dr. Kemble attended medical school at University of Hawaii and Harvard, and he trained in both internal medicine and psychiatry. He's recently retired from private practice, but he still practices part-time in Queen Emma Clinic a hospital-based primary care clinic, including care for mostly Medicaid patients. And he also teaches psychiatric issues and general medical care to internal medicine residents. He's assistant clinical professor of medicine and psychiatry at the JABSOM. He's also past president of both the Hawaii Psychiatric Medical Association and the Hawaii Medical Association. Dr. Kemble has a long-standing interest in health policy and healthcare reform. He was appointed to the Hawaii Health Authority in 2011 and charged with overall health planning for the state of Hawaii and with designing a universal healthcare system covering everyone in the state. He has been a member of Physicians for National Health Program, a physician single-payer advocacy organization since 1989, and he currently serves on the PNHP board. Please welcome Dr. Stephen Kemble.
Thank you. I'm going to share screen. Okay. All right. Okay, as some background to this issue, I want to go into a little brief course on what insurance risk is, how insurance works, because it's really fundamental to understanding the whole problem. Insurance is financial risk management, and it is designed for risks that are infrequent, expensive, and unpredictable. And if all three of those conditions apply, then the primary means of risk management is risk pooling, in which everybody chips in a little as they go along. And then in the few cases where someone needs expensive help, the money is there to cover it. To the degree that the risk is predictable, then insurance companies use underwriting and actuarial analysis, which are designed to identify how much risk there is for the purpose of either charging more or refusing to cover it. Okay, what happens with healthcare? In healthcare, the problem is that way too much of healthcare, the risk is predictable due to pre-existing conditions, demographics, and social determinants of health. And when the risk is predictable, what happens is you either have huge amounts of underwriting, which defeats the whole purpose of health insurance, or you have a situation where you have health plans where their main concern, their main incentive, the driver of competition becomes risk avoidance, of trying to capture healthy people and avoid sick people. Let's say you're starting a new insurance company and you offer a little bit better plan than the competition, maybe a little better benefits, maybe you treat doctors a little better. What will happen is that all the sicker people who see their doctors most often, are going to ask them, should I join the plan? And if the doctor thinks it's a better plan, they'll say, yes, you should join it. That plan will get stuck with all the sick people first and they'll go bankrupt. So you end up with a race to the bottom where every new plan needs to be no better and probably a little worse than the competition to avoid getting stuck with all the sick people. Now, the ACA banned pre-existing condition exclusions and restricted underwriting, but health plans are still very good at capturing healthier than average risk pools and avoiding sicker than average people. So who bears insurance risk? It's whoever has the money and has to cover the variability and unpredictable of healthcare costs. There are some years when you have several really high cost cases, maybe a very premature infant that's got multiple birth defects and is going to need huge amounts of care for the rest of their lives, or someone with a bone marrow transplant for leukemia or something like that. In other years, none of those things happen and you may have lower costs. So there's ups and downs. And whoever is responsible for dealing with those ups and downs has the risk. So if you capitate a health plan, a health insurance company, that means you pay them per member per month. And you say, okay, you take the risk. We're going to pay you X amount of money and you take the risk. You cover the ups and downs. And if they do that, they have risk. And that means if they have a very expensive year, they stand to lose money. And if they have a lower risk than average year, they stand to make money. And if they manage to capture a healthier than average risk pool, they stand to make money. So they can profit or lose depending on how they do compared to the capitated payment. Insurance risk is also transferred in any payment scheme that holds providers of care accountable for the cost or outcomes of care, which largely depend on patient characteristics that are beyond the control of the doctor or the hospital. So if they say, we'll pay you if you have better outcomes than average, you have a very strong incentive to take easier patients, richer patients who can afford their drug copays, who have fewer chronic conditions, who are not too difficult to deal with, who won't take too much of your time. Then you can beat the formula and you can make money. But if you take on anybody, or if you set up practice in an inner city area or a rural area, you're likely to lose money. So social insurance, in contrast to the competitive insurance business model, is pure risk pooling. So it's the government would have to finance it, and you manage the risk by spreading the risk across the entire population using taxes, and you cover all the risks, whether they're predictable or not. That's social insurance, and that's what single payer is. And there's no risk avoidance, no underwriting, no cherry picking a favorable risk pool, no exclusion of high-risk patients or subpopulations, and no gaming documentation to beat risk adjustment formulas. Okay, so an optimal single payer bill should include these four elements. It should have one payer that pays providers of care directly with no subcontracting of funding to risk-bearing entities such as HMOs, accountable care organizations, integrated delivery systems, and other financial middlemen. It should have budgets for institutional providers of care such as hospitals, nursing homes, federally qualified health centers, home health agencies, dialysis centers, community-based programs for patients with specialized care needs. All these things should be paid with a global operating budget and not with capitation or other risk-shifting schemes. Third, there should be a simplified, standardized fee schedule for independent doctors and other healthcare professionals who are providing care, so that billing and payment becomes simple, straightforward, and standardized. And fourth, negotiated prices for controls for drugs and durable medical equipment. Now, you will notice that our Medicare program, which is usually referred to as a single payer program, does not have all these characteristics. It does have one payer that pays providers of care directly, at least in traditional Medicare, but not Medicare Advantage. And it has a fairly standardized fee schedule, although that's been compromised in recent years. It does not have negotiated prices, and it does not have budgets. So it's a less than ideal single payer system, but it's still better than a pure competitive insurance business model. So a risk-bearing entity in healthcare is defined as an organization that has specified enrollees or assignees or members, and is paid by the enrollee or assignee or member, and has a contract with each enrollee or a payer contracting on behalf of each member that obligates the organization to pay for all necessary medical services needed by their enrollees over a given period of time. So that's a risk-bearing entity. And that risk-bearing entity can profit or lose based on the cost of care delivered. And this includes HMOs, ACOs, and integrated delivery systems. So it's very important to understand, and there's a lot of confusion even in the single payer community on this, the difference between capitation and a global budget. A lot of people think they're the same. They are not. Capitation conveys risk, global budgets do not. So with a global budget, you're paying a hospital or a community health center what their cost of operations are. So you look at how many employees they have, what are their salaries, what's their rent or the cost of maintaining their physical building, how much does it cost for maintenance services for the building, any office supplies, all those things. You add up all of their operating costs, and you come up with a figure that's intended to cover those costs. And this can be adjusted with changing circumstances, just like a budget for a police department or a fire department. Police departments and fire departments cannot profit off their budget. If they spend less than allocated, it goes to the next year's operating budget. If something unusual happens and they have to spend more, it's a bad fire season in California, and firefighters have to spend a lot more than their budget, they can ask the legislature for a supplemental appropriation, but they're not expected to profit or lose based on their budget. With capitation, they are. That's supposed to be, this is what you get. You can either profit off it or you can lose off it, depending on how you manage the risk. So there is a current policy fad going on throughout the country. It was enshrined in the Affordable Care Act that says the cause of excessive costs in US healthcare is fee-for-service, which incentivizes excessive volume of care. And that's why our healthcare costs so much. And what we need to do is we need to shift insurance risk onto doctors and hospitals so they have a set amount of money per person and they're accountable for the cost of care. And if they manage to spend less than that capitated rate, they can keep the difference as profit. And if they don't, they lose. And managing that risk requires a lot of data. And I really think this is the real reason why the insurance industry really pushed for the Affordable Care Act. The people that helped Obama design it were from the insurance industry, because the requirement for big data cements the role for insurance industry in healthcare. You cannot be a small practice and manage insurance risks. You need all this information about the details of how sick your patients are, and so that you can cherry pick and lemon drop and follow the incentives of the model. Otherwise, you can't do it, and you're gonna go broke. The problem is we have never actually had excessive volume of care in the US. Our doctor visits per capita and hospital days per capita are among the lowest of industrialized countries. So this is based on a false premise from the get-go. So this idea started of shifting risk to providers started in the 1990s with managed care, capitation, and HMOs, but there was a backlash because of the incentive to skimp on care. Then in the 2000s, we started getting pay for performance or pay for outcomes and quality metrics, adding administrative burdens in an attempt to prepare for value-based payment. And in the 2010s, we get value-based payment in ACOs. Accountable care organizations are ACOs, which includes capitation, bundled payments, more pay for performance and quality metrics. And value-based payment is being promoted by the Affordable Care Act and CMS through Medicare and adopted by many commercial and Medicaid plans. So an HMO is an integrated system of multi-specialty physician group practice and an affiliated hospital or an affiliated independent practice group or network of independent practices affiliated with hospital or hospitals. And this chain of doctors and hospitals is called an integrated care system that assumes responsibility for the healthcare of identified subscribers or enrollees and takes on insurance risk. And enrollees of an HMO know they are enrolled in the plan. Kaiser is the preeminent example of this. A classic closed panel HMO, there are also open panel ones where doctors see HMO patients and non-HMO patients both in the same practice. And Medicare Advantage and Medicaid managed care are both HMOs essentially, where you know you're in the plan, you've signed up for it or been assigned to it, and you're told which plan you're in. An ACO is created under the Affordable Care Act, and it doesn't have patients signing up for the plan. They are attributed based on where they seek care most often. So they may not even know they're in an ACO, but once they've been attributed to a practice, then that practice can be capitated and have risk shifted onto that practice. And this requires quality metrics, pay for performance, and risk adjustment to manage the risk. And that requires detailed documentation and data reporting, and that means high administrative costs. Risk adjustment, the idea is if you have sicker than average patients, we're going to pay you more. And that would counteract the incentive to cherry pick and lemon drop. The problem is the risk, the predictable risk in healthcare is extremely complex. And risk adjustment formulas are crude, and they may capture about 10 to 15% of the variability in cost of care. And this means that if you are getting a risk adjustment payment, it's not going to cover the whole range of risk depending on your patient population. And so you still have an 85% incentive to cherry pick and lemon drop. And if you try to make risk adjustment more accurate, you need more data. And if you try to get more data, you're going to add more administrative burdens and costs. And we're already at a point where the administrative burdens and costs are becoming intolerable. So it's like pushing a rock up a steep hill, and it's getting steeper all the time. And it's going to stall out at somewhere less than 20%. And we're never going to get effective risk adjustment. It's impossible. So as I said, utilization of care in this country is actually toward the low end of industrial countries and often uses fee-for-service. So fee-for-service cannot actually be the cause of our high healthcare costs. And there's plenty of evidence that the real cause of our healthcare costs is excessive administrative costs, not excessive utilization. All right, so let's say you do risk shifting because you believe that fee-for-service is the problem and you want to get away from fee-for-service as CMS does, and you want to capitate doctors. And so you say you have a fixed amount of money, you've got to deliver whatever care you're responsible for this population within this amount of money. So you have an incentive to skimp on care, and you have an incentive to avoid sicker and more complex and socially disadvantaged patients. So the counter incentives are pay for outcomes, which is supposed to assure quality and that you don't skimp too much on necessary care, and risk adjustment, which is too complex to do accurately. So neither one, measuring outcomes or quality, is also extremely complex, and you can't get close enough to actually be effective. So that too just adds more and more administrative without accomplishing the whole goal. So if you're relying on competing risk-bearing entities like insurance plans, and you're saying, well, we're doing this because we need competition, because competition is going to control prices. Well, the administrative cost of using competing insurance plans is 5 to 6 times that of a public system. The incentive is to avoid risk. So there's a race to the bottom among plans, a misguided and costly effort to manage healthcare via bureaucracy. And insurance plan competition does not improve healthcare, does not reduce costs, and it does not add value. It adds administrative costs is what it does. This is a famous PNHP graph that many of you have probably seen. I just want to point out that this steep part here is the managed care era of the 90s, where administrators shot up. And this bump here is the Affordable Care Act's value-based payment bump, where administrative costs are again shooting up. So there are quite a few single-payer bills that do allow HMOs or ACOs or integrated delivery systems. They're trying to accommodate systems like Kaiser, because many people are happy with the care they're getting at Kaiser, and they're afraid that Kaiser is going to be disbanded. And we'll come back to the solution to this problem later. But when you have a single-payer bill and it allows HMOs and ACOs, and it pays them with capitation and shifts insurance risk onto them, this perpetuates the competitive insurance business model, and it makes a single payer system a multi-payer system. So it makes it not a single payer system. And this is what I call a Trojan horse for the insurance industry. And if any of you aren't familiar with Homer's Iliad, a Trojan horse is during the battle for Troy. The Greeks built a huge wooden horse, and they wheeled it up to the gates of Troy as a gift to the Trojans, as a peace offering. And they wheeled the horse inside the walls of Troy, and inside were a whole bunch of Greek soldiers who jumped out and slaughtered the Trojans and won the battle. So that's what a Trojan horse is. So these are bills that contain an HMO ACO loophole. Bernie Sanders S1129, New York Health Act, and the Healthy California Act, SB 562. All of these allow HMOs and ACOs to appease Kaiser, or to include Kaiser. You cannot do the second one of those 4 characteristics of an ideal single-payer system, which is budgeting of hospitals, if you're going to pay for hospital care through risk-bearing entities. So if the HMO is supposed to cover hospital care as part of what their contracted responsibility is, you cannot both budget the hospital and pay it through competing HMOs and ACOs both at the same time. Otherwise, you'd be double paying the hospital. There are some bills like Whole Washington Trust Bill and the Mass Care Bill that seem to be confused and try to do both. So they call for budgeting of hospitals and they call for capitation. Maybe they mean capitation for doctor services only and not for hospitals, which might be possible, but it still makes, it still does shift risk onto providers of care and makes it not quite a true single payer system. And then the bills that have no HMOs or ACOs and do have global budgeting for hospitals are Jayapal's HR 1976 and the California Guaranteed Healthcare for All Act, AB 1400, a true single payer bill. So the arguments for ACOs and capitation are that capitation, this is primarily for doctors. Capitation allows flexibility in how care is delivered. So if you're paid per month per patient, and it's not based on paying per visit or per service provided, you can be flexible in how you deliver care. So you may want to use, during a COVID-19 pandemic, you may want to use telephone or telehealth visits, and you're being paid a fixed monthly amount per month. So it doesn't matter if the patient comes in or not, as long as you're responsible for their care and you're following through on that responsibility, you can do that. So there is flexibility in how care is delivered. And you can rely on lower level practitioners in your practice, more nurse practitioners and case managers and things like that. Hire a social worker as a psychotherapist. So you're not locked into any particular procedures that are covered with fee for service. You can be flexible in how you deliver care. And that can be a good thing. And capitation can allow funding streams for care coordination. So let's say you're capitating an insurance plan, and they use some of that capitated money to pay for case managers to go in the community and help make sure patients follow through with their taking their medicines properly, that you can have visiting nurses to maintain a complex medical patient in the community to keep them out of the hospital. You can do things like that that don't fit under the procedure codes for fee for service. And during the pandemic, your income doesn't stop if patients stop coming to the office. And you have somewhat more predictable budgeting for a third-party payer. However, once let's say a government payer capitates health plans, they lose control of the budgeting process because the health plan says, we'll cover your healthcare needs for X amount per person per month. And the state says, great, that makes our budget predictable. But let's say that the health plan discovers that they're on the verge of losing money at that amount. They can come back the next year and force the state to raise the capitation rate. And they can do that every year forever. And the state, having let go of control of their budget, can't argue with them. And especially because the health plans are very good at giving deceptive financial data. And so they are able to force the state to pay whatever they want forever. Arguments against ACOs are the high administrative costs for both the practice and for the ACO itself. Capitation rates often fail to account for administrative costs. Capitation exacerbates disparities in access to care because it incentivizes cherry picking and lemon dropping. And if the capitated rate is inadequate, then big time doctors will avoid sicker patients and get rid of time consuming or higher risk patients. And they'll be very tempted to take on more patients than they can handle to get more capitation payments and then not be able to provide adequate care because they have too many patients and they're too busy. And capitated payment, the capitation rates often vary with the practice, and there are complicated formulas health plans use to determine them. And this makes it impossible to predict what your income and expenses are going to be if you're starting a new practice. So this has been a major cause of Hawaii's rapidly worsening physician shortage and the fact that no new doctors are willing to set up practices here. All right, so what's the solution? What to do about Kaiser if you want a true single payer system that's going to pay hospitals with budgets? And the solution is actually quite simple. You keep the doctors in the hospitals, you make sure that they are kept whole, and you throw out the insurance plan. So a physician group practice affiliated with a hospital may elect to be paid through that hospital's global operating budget, with the doctors paid with salaries from that budget. This means there are no members or subscribers. It's an open system. Anyone can get some of their care from Kaiser and some of their care elsewhere. If you're happy with Kaiser's primary care, but not their psychiatry department, you can see a psychiatrist outside Kaiser. You don't need to worry about out-of-network bills, surprise bills, things like that, because it becomes an open system. There's no members or subscribers. There's no capitated payments. The hospital and doctors are paid according to their operating costs, not according to a capitation rate. There's no retained earnings or profit or loss, no financial risk. And there's no funding for corporate chain management. So each hospital with an affiliated physician group is financed separately by the single payer system, and there's no chain. So hospital corporate would disappear. I mean, Kaiser corporate would disappear. Kaiser as an insurance plan would disappear, but the hospitals and the doctors would be kept whole, could work together, could have a shared electronic record to do all the nice things that Kaiser does, but not have the insurance function. And there'd be no corporate chain trying to interfere with how doctors practice medicine. It's very important to have societal control of healthcare resources if you want to correct disparities in access to care. And when you ban retained earnings, profit or loss from a hospital with a global operating budget and have no funding for corporate chains and separate budgets for capital expenditures based on community need, then you can allocate resources where they are needed instead of where a chain management CEO thinks they can make the most money. And the goal should be equitable access to care in all communities and not making a profit off of healthcare. You can coordinate care without HMOs, ACOs, IDSs, or capitated risk-bearing entities of any kind if the single payer funds care coordination directly. So let's say you need visiting nurses and care managers to handle complex patients or patients who are prone to be frequent flyers in the emergency room. You can contract with a service agency that actually does that directly from the single payer, pay them an operating budget and say, we'll pay you to hire so many case managers and so many visiting nurses, and you can cover the needs of this community, and we'll pay you what it costs to do that. And you don't have to, figure out who your members are. You're just there available to the community based on patient need, and any primary care practice can call on you if they need help. You can do similar things with community-based services for high risk and special needs patients. And a great example of this is the collaborative care model for psychiatric consultation to primary care, which I am doing here in Hawaii, where we have a team of psychiatrists for 2 hours a week, a full-time social worker, care manager, and some administrative support that is available to primary care practices whenever they have a psychiatric problem. So let's say a primary care doctor has a patient who says they're feeling suicidal. They call us, the care manager talks to the primary care doctor, talks to the patient, gets a full psychosocial assessment, presents the case to the psychiatrist at their weekly meetings. The psychiatrist then gives the primary care doctor specific advice on how to manage the case, both medication issues and non-medication issues, and any recommendations that would help the primary care doctor manage that case appropriately. The primary care doctor then is the one that prescribes medications, but the psychiatrist is following along as often as necessary to be sure that any problems are dealt with properly, and the primary care doctor knows they're doing the right thing, and the care manager is in contact with the patient regularly to make sure they're following through. And this enables primary care practices to deal with about 80–85% of the psychiatric problems they encounter in primary care without having to refer them directly to a psychiatrist. The same thing could be done for any other specialty consultation that doesn't require an immediate procedure. And you could do this for complex diabetics or arthritis patients or a whole bunch of other specialty consultations. Quality improvement, if you're not going to have risk-bearing entities, quality improvement should be funded directly also. And it should be founded on the professional motivation to serve patients, not pay for performance and financial incentive. Intrinsic motivation, not financial incentives. And we used to do this in this country through Medicare. Every Medicare every state's Medicare program had a quality improvement organization, and it was all based on the professional desire to improve care with no financial incentives involved. That's what we need. And we should fund any necessary administration, such as claims processing, support for quality improvement, any other administrative support needed with non-risk administrative services only contracts. So this, you can hire an insurance company, but you don't pay them to take on insurance risk. You pay them to do the operating costs of claims processing, credentialing, and any other things that are included in your contract that they have to do, but there is no risk. It's just like funding the police department or the fire department. They're paid to do a job, but they're not paid in a way that enables them to profit or lose based on that budget. Connecticut Medicaid did this for their Medicaid program. They fired their managed care companies, which they had had in place for a dozen years. In 2012, they hired one of those former managed care plans, which is a local nonprofit one, to be their administrative services only contractor. And they paid doctors directly, and their Connecticut Medicaid program retained insurance risk. So they covered the ups and downs. 6 years later, their physician participation had improved 30%. Their ER visits had dropped 25%. Their hospital visits had dropped 6%. Their administrative costs dropped from 25% to 2.8%. And their total per member Medicaid costs had dropped by 14%, 6 years out, compared to going up about 10% per year in the 4 years prior to doing that. The cost came down 14% over a 6-year period. So 6 years later, it was 14% lower than it was in 2012. So a good single payer bill must ban HMOs, ACOs, and capitated IDSs, but can pay a doctor group in a hospital with one global budget. They should not use capitation or case rate payment or bundle payment or other forms of value-based payment. They should not use pay for performance based on cost or outcomes of care. And they must ban duplicative coverage from other sources for essential benefits covered by the single payer. Questions?
Well, before we get to questions, big applause. That was incredible. I hope that you'll share your slideshow with us.
I will put it up on the chat now, which I can do in Zoom.
That's amazing. Thank you so much. Okay, I'm gonna look. So we do have some questions in the Zoom, and Betty, I don't know if you are still with us on, I see your name on our Zoom. I just don't see you. But Betty will be our moderator from Facebook if there are any questions on Facebook. But I'll go ahead and start. And I see Maureen has a question. And she says, you have established that administrative costs are responsible for intolerable and unnecessary expense to the system. But what about the hospital prices that are well beyond the cost and offer enormous profits? It continues on. It says, how much does that affect the system? California hospitals made $97 billion in profit during COVID. Kaiser has made about $7 billion since January 2020. So I think that's the first couple of questions, and then she has a second part.
Well, that's an excellent question, and it requires getting a little more nuance about fee-for-service, because I don't think there's much evidence. In fact, I've never seen any evidence that primary care doctors deliver unnecessary care when they're paid with fee-for-service. But there is evidence that hospitals will deliver unnecessary care when they're paid with fee-for-service. Hospitals need to be taken off fee-for-service entirely, and that is the reason you want to pay them with a global operating budget. So if they're paid a global operating budget, which is based on their cost to operate, they are not paid $10 for every Band-Aid. They're not paid per procedure. They're not paid per patient. They're paid the cost of running their operations. How much does it cost to run the hospital? hire the doctors, hire the nurses, hire the physical therapists, hire the housekeepers. How much does it cost to do that? But there's nothing in there that pays per procedure, per patient, per anything on a fee-for-service basis. It's just operating costs. That eliminates the problem that you just mentioned.
Thank you. And then the second part is fee for service is getting paid for what a provider does. Capitation can be getting paid for what is not done.
This also requires a little more nuance. I think generally it's very hard to pay an independent practitioner with anything other than fee for service, because you can't pay them with a salary if they have no employer, if they're self-employed. And if you pay them with capitation, you have all the perverse incentives of risk shifting, which we went over. I have another proposal, which is on the One Payer States policy papers website under policy papers, on how to pay doctors with fee for service. It's not the way we pay doctors now. Right now, our fee for service system is a system for pricing procedures. So it says, you know, a tonsillectomy costs X. A office visit for evaluation management services in a moderately complex patient costs Y. So it's a pricing system for procedures. What I think we should do is have fee for service that prices the time and expertise of the doctor, which is the same way any other well-educated professional is paid. We pay attorneys that way, we pay engineers that way, we pay architects that way. Any other highly educated professional, you're paying them for their time and expertise. With doctors, we pay them by the procedure. So what I would do is I would do audits of physician practices, find out how much time is associated with all uncomplicated procedures, and set that as a standardized time. And for office visits for cognitive services, you let the doctor and patient decide how much time they think that patient needs, which is how psychiatrists were paid up through 2012. So if you have a patient who's pretty straightforward, they're just checking in every 6 months, but they're doing okay, you might schedule them for a 10 or 15-minute visit. If there's somebody who tends to ramble and it's hard to get them to the point and they have multiple problems, you might schedule them for 45 minutes. Or if they have a crisis going on and they have a lot to talk about, you might schedule for a longer visit. But you and the patient decide how much time to allocate. And the hourly rate is determined by how many years of training were required for your specialty. So with primary care, most primary care specialties have 3 years, they have 4 years of medical school and 3 years of postgraduate training. So there would be a certain hourly rate for a general primary care practice. If you specialize in something that requires extra years, you get paid at a higher rate for treating that patients with problems that fall under that specialty. So there would be adjustment for the need for higher training, but everyone with the same number of years of training would get the same hourly rate, and the hours would be tied to every procedure, but because each procedure would be associated with a time. You could also pay for anything that was not an office visit in the same way. So you might pay for telehealth or telephone visits. If you have a COVID pandemic and patients can't come to the office and you're going to do extensive care over the phone, you could pay for time the same way. You know, if the doctor spends an hour treating the patient over the phone, it should be paid the same as if they spend an hour treating the patient in the office. So you could cover a lot of the things that are cited as advantages of capitation with a time-based fee-for-service system. And it's much harder to game time because there are only so many hours in a day. If a doctor is billing for 20 hours a day every day, obviously something is wrong. It's much harder to game because it's objective, it's simple, it's straightforward. The patient knows what it is. It's not complicated and arcane the way our billing system is now. So that's how I would do fee-for-service for independent doctors.
Thank you. Paul or Betty, do we have a question from Facebook you can share?
Well, there's a comment from Leland Young from Berkeley, California, and he writes, "We have a hybrid system that is the worst in both worlds for the public. Insurance companies cover mainly the healthy and the working population, with the lowest Medicare bills and make millions in profits. The government covers the population with the highest medical expenses. If we get too sick or injured to work, we lose our jobs and go on a government system eventually. It's a statement. Do you have anything to say to that?
It's completely true. I totally agree. And putting hospitals on global operating budgets instead of fee-for-service would eliminate much of that, and eliminating corporate chains and corporate management of healthcare facilities would eliminate the rest. So all of those problems would be solved with a single payer system that had the four characteristics that we started with as their foundation, including AB 1400.
Thank you.
Big smiles every time you mention AB 1400. Thank you.
So
love our bill. So
I'm just going to chime in. I know that Eric has been invoking my name several times, but I'm doing all the tech in the background and trying to figure out the ever-changing Facebook, who decides how you're going to change how to post a video, live stream a video, and where the comments are. Because it looks like there's 15 comments, but it's only showing 4. So I'm trying to figure out if there's any more questions. And I might not be able to do that at this moment, but we're trying.
all right. Thank you so much, Betty. And I'll just keep checking in with you and Paul. So just appear when you have something for us. Thank you so much for that, Betty. But we do have some other questions in our Zoom. Cheng Sim asks, can you explain how capitation in a single payer system makes it multi-payer?
If capitation can occur at a plan level, at a doctor group level, or at an individual doctor level. If it's at a plan level, it's obvious, because if a single payer like a Medicaid program hires 6 different managed care organizations to cover their Medicaid population and capitates each one and says, okay, now you guys compete with each other. You now have 6 different payers who are risk-bearing, and depending which plan you're in would determine which plan pays for your care. And they all have that incentive to cherry pick and lemon drop and game documentation and try to profit off it, because that's the insurance business model. If you capitate a physician practice, it becomes a little more difficult to see what's going on, but that physician practice also has an incentive to take on easier patients, wealthier patients, patients who can comply with treatment, who can afford their drug copays, who will follow through, who will be responsible, and to avoid anyone who doesn't meet those criteria, so that they can make money off the capitation rate. Now you've turned the doctor into a little insurance company. And if you have 5,000 doctors, you've got 5,000 little insurance companies, and you have a multi-payer system. Because the doctor has been given a set amount of money, they've got the risk, they've got to cover the care, they are now a little insurance company.
Thank you so much for that. Here is another question from Margie. Given our dealing with a pandemic showing the weaknesses across both direct care and public health, how will single payer interface with public health?
Public health is something that should be funded as one of those globally budgeted things by a single payer, which is how public health departments in state government are funded, or in federal government are funded. They're given a budget. They don't profit or lose off it. It's not capitation, but they're paid to do a job. And that should come directly from the single payer as part of their budget is funding public health. And obviously it should be more adequately funded than it has been, especially because public health events are quite variable. You have a year when nothing much happens, and you have another year when COVID happens, and smaller outbreaks here and there in between. So you need to give them an adequate budget so that they're ready when something big happens, like what's happened in the last year. And it should come directly from the single payer as an operating budget.
Thank you. Paul and Betty, do you guys have anything, or you can just interrupt me or let me know when you do?
When I see some, I'll let you know.
Thank you. Here is a question from Linda. Will there be, or how will there be, equity for those areas underserved now in terms of both physicians and hospitals with single payer? At the moment, there are so many underserved.
There are severe inequities in access to care, and that's a very good question. The first thing is that right now, because you can make more money practicing or setting up a hospital in a wealthy neighborhood than in a poverty area, because the rates of pay are lower for Medicaid, the patients are sicker. If you are capitated or have insurance risk pushed on you, you're going to have an incentive to avoid poor people. So there's all these things that really aggravate disparities in access to care. If a system is paying hospitals with operating budgets and they have separate budget for capital expenditures, and those are allocated according to community need, instead of a hospital chain building a new hospital next to another one in a wealthy neighborhood, you would have the single payer saying, we don't have enough hospitals in the inner city, we need a new one there. Because every hospital would be paid for their operating costs, there would be no such thing as profitable and unprofitable hospitals. The system would be responsible to make sure all those hospitals stay afloat. If none of the hospitals are allowed to use fee for service because their entire costs are paid with an operating budget, then they have no way to profit or lose depending on where they're located. Wherever they are, they're going to get paid what it costs to operate, and they can serve the patients in that community. With my fee for time proposal for physicians, the current fee for service system in Medicare has three components. It has a physician work component, it has a practice expense component, which is not accurately determined, and it has a malpractice cost component. If you took the practice expense part and you, instead of doing surveys of doctors and saying, how much does it cost you to run your practice, and then they lie, you would do audits of their books. You would find out how much did they spend in the course of a year running the practice, minus the physician's personal income, and that's their office overhead. And you would average that for a given specialty, and you would pay as a flat rate, this is your operating, but this is your practice expense budget based on your specialty. If you do that, generally what that does, it means that practice expenses are paid at cost, and the work component becomes the determinant of your personal income as a doctor. So you mainly, if the more you work, the more you get paid, and you're paid according to the years of training required for your specialty and the hours that you put in. So it's reasonable and fair. But on the practice expense side, if you're paid an average cost to run an office, and you set up your practice in a wealthy neighborhood, you're going to have a little less of that money to keep, because you're going to be paying more than what the allocated amount is for a high rent area. If you set up your practice in an inner city or a rural area, you're going to have lower than average rent, and you can keep the difference. So there's actually an incentive to set up practices in underserved areas, because you make a little money off that practice expense component of fees. I think between eliminating the incentive to profit off of only taking care of healthy, wealthy patients and adding a small incentive to practice in underserved areas, and you can also, a single payer system can adjust fees to say, we are going to pay more if you practice in these areas where we really need more people. You can do that at a single payer board level, trying to make sure the community needs are met. You can make adjustments to the fees that way too. So there's three ways you could correct disparities. And I think that would result in huge improvement in equity of access to care.
So, Dr. Kemble, I have a question. I'm not exactly clear what the question is, but I think what the person is referring to is what you were working on before the ACA came into play. I think you had mentioned something that you had in Hawaii, you had something close to a single payer system, and then the ACA came along and kind of ramshackled that. Possibly, I think that's what they were referring to.
That's correct. Hawaii, since 1974, Hawaii has the Prepaid Health Care Act, which we were given an ERISA exemption because it was passed just before the ERISA law was passed. And we got a waiver to exempt Hawaii from ERISA as long as we didn't change the Prepaid Healthcare Act. And that requires anyone, it has an employer mandate, anyone working 20 hours a week or more has to provide health insurance to their employees, or their employer has to provide them with health insurance. No pre-existing condition exclusions and no deductibles. The co-pays are limited to 10 or 20% of the fee, but that's the only patient cost sharing. There's no deductibles, and there's no pre-existing condition exclusions. And we've had that since 1974. And this is the most progressive healthcare law in the country prior to the Affordable Care Act. We also had a relatively generous Medicaid program, which covered everyone who any doctor said was disabled up to 200% of federal poverty level, which is better than the ACA, except you had to be certified as disabled. So with that combination, we were doing pretty well, but there was a recognition that anyone working less than 20 hours a week fell through the cracks. Individuals who didn't have an employer fell through the cracks. And there were a lot, and the Medicaid program was turned over to managed care plans, which screwed it up. So there's plenty of problems. So we had a Healthcare for All Hawaii, similar to your organization, that was pushing for single payer for years. And one of the leaders of the movement was a woman named Aquan McElrath, she was about a 4'11" Chinese woman married to an Irishman. And she was a firebrand for social justice. She worked a lot with labor unions, and she was always down at the legislature. Everyone knew her. And she had pushed for the creation of the Hawaii Health Authority, which is supposed to design a universal system covering everyone in Hawaii and be responsible for overall health policy. Well, she died in 2009. And a couple months after her death, the legislature finally passed the bill to create the Hawaii Health Authority. And we had a Republican governor at the time, and they overrode her veto to implement the law. But she refused to appoint anybody to the Hawaii Health Authority or to implement it, so it languished. 2 years later, our former Congressman Neil Abercrombie became governor, and he had been a co-sponsor of HR 676 and a single payer supporter when he was our congressman. And once he got into office, he did appoint the Hawaii Health Authority, and I was one of the original members. And we started planning for a universal healthcare system of how to get from where we were to something as close as possible to single payer. And that we worked on that for 2.5 years. And he appointed us in 2011. At the same time, the Affordable Care Act passed. And Abercrombie had known Obama's parents when Obama was born. And he wanted to be the flagship for implementing Obamacare. So he had no money in his budget to do that. So we had been given $100,000 from the legislature to hire an executive director. He took that away. He called the insurance companies, the insurance plans in and said, will you help fund a payment transformation initiative following the Affordable Care Act? And he threw us under the bus and ignored everything we said. So we met for 2.5 years, submitted 3 reports to the legislature that got totally ignored, and we were basically stripped of any ability to actually influence policy. And the Health Transformation Initiative, I was on that because I was representing the Hawaii Health Authority, and they completely ignored anything I had to say, anything anyone who was a frontline provider of care had to say, and they did exactly what the insurance companies wanted to do. And the minutes didn't reflect any of the discussion that went on. They just whitewashed it and came to the insurance-friendly conclusion. The whole thing was a joke. And it was funded by the insurance industry. So that's where we are now. We're stuck in dysfunctional Obamacare, and we're trying to get the Hawaii Health Authority reactivated.
Wow. Yeah. We're seeing that with our Healthy California Commission. Seeing a lot of similarities. We've got Carmen Comsty and Dr. Rupa Myra, who are pro single payer, and they're constantly saying our comments aren't in these reports, you're not listening to what we're saying. But
the reason they don't listen is it's the usual thing that insurance companies have a lot of money. They throw it at politicians who listen to them as a result, and they don't dare not listen to them. And the result is anything that is helpful to people other than insurance executives gets thrown under the bus. That's what we're all dealing with.
Yes, and just thank you so much for not getting run over by the bus and being with us today and continuing to jump on the bus, steer the bus, and we will keep going. So we're almost at time, but we do have a couple of more questions. Are you okay to answer a couple more?
Sure.
Okay. So this is Marine. It says, it seems increasingly people are waiting for care in Kaiser. How does delaying patient access to care in the current system help increase profits?
Because Kaiser makes more money by getting more members and delivering less care. That's how they make more money. So one way they do that is they market to healthy people who don't need or want much care. Our Kaiser system in Hawaii, their theme on their ads is thrive, with pictures of seniors exercising and things like that. So, you know, we're the plan for you if you're healthy and don't need any care. And they also are not very helpful for people with serious mental health problems. And when I was in private practice of psychiatry, I had many Kaiser patients who were seeing me and paying out of pocket because they were so unhappy with what happened at Kaiser. And so those are expensive patients often, and they get driven out of Kaiser. They give up on Kaiser, they get disillusioned, and they go back to something else. And so Kaiser is cherry picking and lemon dropping. They do this at the plan level. I don't think they push insurance risk onto their doctors, at least not very much. So generally, Kaiser doctors treat everyone the same, whether they're a Medicaid patient or a commercially insured patient. Once you're in Kaiser, you get pretty standardized care, which is the good part about Kaiser, but the plan is definitely cherry picking and lemon dropping. Kaiser in Hawaii has always been a little bit lower than the major Blue Cross Blue Shield plan, which is HMSA. HMSA has 70% market share, and Kaiser is around 17, 18% market share. And Kaiser is always a little bit lower than HMSA, but no matter how much HMSA's premiums go up, Kaiser always follows them at 97%. So if Kaiser is truly a more efficient system, where's the money going? It's not coming in the form of lower and lower premiums compared to HMSA. It's getting kept because Kaiser management wants that money as profit to fund empire building and that kind of thing. They're technically not for profit, so they can't call it profit, but you can hide a lot of money in administrative expenses that you call healthcare.
Betty, I see your hand raised. I'm not sure if that's old or if
No,
you...
actually, I was just had a comment because I experienced something a little different from insurance companies. That I don't, maybe it's not different. I just wasn't aware of this. And, you know, I have a PPO insurance, right? Yeah. And I just, a way they cut out, how they're cutting things out without us even really possibly realizing until we actually have the need for something. And I have a covered insurance. It's not a PPO, but I'm going to a covered participating physician's office. They referred me to a program that's in a physician, is actually at, it's a surgery that will happen at a covered hospital that's underneath my plan. And when I was sent to the referral and I talked to the hospital, they said to me, oh, that particular procedure, they will not cover that procedure at our facility. They will cover other procedures, but not that one. I'm just appalled on how is the public supposed to even know this? You purchase a policy thinking I have these hospitals that are gonna these facilities, and then they're really not. They're really not covered.
This is why when they do surveys of satisfaction with your health plan, 70% of people are happy because those are the people that never use it. Those are the people that hardly ever see a doctor. the 30% that see a doctor a lot are all unhappy, but you wouldn't know that from the customer satisfaction survey.
Thank you, Betty, for sharing that. I think Lynn had a question, but I think she might have been having an issue and couldn't type it in. Lynn, if you wanted to unmute and share your question.
Can you hear me?
We can hear
Yeah.
you.
Oh, hi.
Hi.
I have both things on. I have Facebook and Zoom on my phone. So I'll ask real quickly. Maybe you mentioned this, but there's a lot of group practices where I live, Alta Medical Foundation, etc. Would they be paid by global budget?
If you have doctors, well, in AB 1400 and HR 1976, they would be paid with global budgets only if they affiliate with a hospital. So if they elect to have their doctors paid with salaries through a hospital's global budget, they can have an agreement with that hospital, and the single payer will pay enough for both hospital operations and the salaries of the doctor group. And so that would be if they affiliate with a hospital. If you have a group practice that are independent of a hospital, they'd be paid fee for service. And as I said, I would pay them fee for time, according to my proposal, which I think is the most cost-effective way to do fee for service.
Thank you. Hold on, let me just make sure everybody's muted.
I have one other question.
Sure.
Go ahead, Lynn. We may have lost Lynn. You're unmuted, Lynn, if you want to go ahead and try again. Okay, there's another question in the Zoom, but we'll come back to you, Lynn, or you can type it in the Zoom chat. And let me see. Okay, Maureen has a question. Does the psych consultation method have a delay in getting the treatment? What happens in emergencies? Who takes charge of a patient in a psych emergency when the patient is a first-time emergency?
Okay, I don't know how it is in LA, but in Hawaii, if a primary care doctor refers a patient to a community psychiatrist, they often have to wait 1 to 3 months for an appointment, which is completely useless for an emergency. With the collaborative care model, the care manager gets back to the primary care doctor and the patient within 1 to 2 days and starts the process of engaging the patient in treatment. We have a weekly interdisciplinary team meeting where they present the cases to me, but if they need something urgent in between, they can just call me and I can answer a question right away. And so basically the wait is 1 to 2 days. If it's in something that needs care within hours, they get sent to the emergency room. But it's generally 1 to 2 days. And I can cover, in 2 hours a week of my time with a full-time care manager, we can cover 80–85% of the psychiatric needs of 15 primary care practices, which is huge leverage of my time, way more than what I could do if I were just accepting referrals in private practice from primary care doctors.
I so appreciated that part of your talk. I recently had an experience with a friend. I'm sure many of you know there are people who've been struggling more so with depression and things like that because of COVID. And, you know, the psychiatrists, right, are the ones who can handle medication and things like that. The I don't know, the concierge ones or the ones that don't take insurance, $600 for a consultation fee.
Yeah.
This person couldn't do it.
Yeah.
So she went to her primary care physician, which, you know, is in a good whatever network, UCLA. And the answer, you know, do you have anybody you can refer? She asked if they had a psychiatrist they could refer her to. And the answer was, just go look on the back of your insurance card and start calling to see who you can go to. And the thing that I don't think that, because I was trying to help her, figure out and break it down into steps, and we can do it together. Because, when a person is depressed or struggling like that, I mean, it was another overwhelming obstacle to getting care.
Yes.
And it couldn't even motivate. Like, she had to keep remotivating herself first to ask. And it's like, it's too expensive. Then to the doctor to ask. And it's just like, keeps getting shut down. And, and as we know how the insurance goes, it's like, they tell you this is insured. So anyway, I think it's great that you work with the primary doctors like that. Like, she could have just gotten it through her primary doctor working with you. So it's a comment, not a question. But
yes, and we can give the primary care doctor very specific advice on managing medications so that they then feel comfortable writing the prescriptions because they have our backup and we follow through. And I really think the quality of care the patient gets is as good as or better than what I could provide myself as an independent psychiatrist, because the care manager can follow people more closely than I could.
Amazing.
Mostly by telephone.
So I just want to check in with Lynn, because I think she was trying to ask a second question, and then we'll take our last question after that, coming from Paul Newman, if you're okay with that, and then we'll close out. Does that work for you?
Sure.
Okay, so I think Lynn dropped off, actually. So we will go to our last question. Paul Newman.
Yes, thank you. This one's from Facebook from our own Chris Shimizu of Beverly Hills. And she asked, how did unions respond when you came close to getting single payer in Hawaii?
The Hawaii Health Authority bill was supported by several of the labor unions, but we've had very mixed response from labor unions with regard to trying to reactivate the Hawaii Health Authority. And we have two things we're pushing for now. One is to deprivatize Medicaid, do what Connecticut did, kick the managed care plans out, have the state take back insurance risk and run it directly. When Hawaii used to do that before managed care, all the doctors took Medicaid. Now almost none of them do. So we really think that would help a lot. And we're trying to do the same thing with state and county employee, retiree, independent healthcare coverage because that's under state control. And if the state were to take it back from the insurance companies and run it the same way Connecticut runs their Medicaid program, directly with an administrative services only contractor for claims processing and community-based programs for special needs, we could do the same program for Medicaid and for all state and county employees, kick the insurance companies out and do it right, prove that it costs a lot less, and that could become a foundation for a single payer system. So that's what we're pushing for right now. But we have a ways to go to convince the unions that they would actually do better with this, because they're all afraid of change, even though they're paying through the nose for HMSA and Kaiser here.
But I would also say that a lot of it's the union leaders that are taking that position, and the rank and file, are not being educated about single payer by their union leaders, or B, they are in support of that. We saw that out here in Las Vegas with Medicare for All, where there was a union, I'm blanking on the name, but it was like Culinary Union or something, and the leadership came out and said, they didn't support Medicare for All, and the rank and file put together a letter and they were like, we do. And so so I just wanted to add that.
I think that's true, and part of the problem is the same thing with everything else, that you have union leadership who are appointed to board of directors for health insurance companies, and they're all in bed with each other, and they have a vested interest in sabotaging single payer, even though the rank and file may not feel that way at all.
Right, sort of like what we see here, and I mean, we have a Democratic supermajority here in California, and it's, the people who are registered as Democrats overwhelmingly want single payer in California. And then, our leaders, they say that they do, but then, it's killed in backdoor meetings, or they say that they support it, but not AB 1400, not now.
It's exactly the same here. We have a supermajority in both houses also, and it doesn't get us anywhere if they're all bought off by the insurance companies.
And I would just say, if you don't support AB 1400, then you don't support single payer. Yeah. So I did miss a question. I promise this is the last one, but I'll feel bad if I don't ask it. It's from Chung Sim, and this is the last question. Chung Sim asks, what do you say to those who say they support single payer but are concerned that it dampens innovation?
What was the question again?
What do you say to those who say they support single payer but are concerned that it dampens innovation?
I don't know where they're getting their information from, but the thing that dampens innovation is insurance company micromanagement of doctors, not single payer. And single payer would get rid of that, and it would free doctors to innovate.
Well, thank you so much, Dr. Kemble. Thank you, everybody here, Healthcare for All Los Angeles. Thank you for everything you're doing. We do have a bill, everybody, AB 1400, CalCare. Please visit our website, hcala.org. Click the Take Action. Click Do You CalCare. There you will see actions you can take. You will see the toolkit from CNA, California Nurses, who wrote CalCare, and much appreciation and love to you all, and CalCare now.
I put both the PowerPoint and a PDF handout of it on the chat toward the top.
Thank you so much. Can we unmute and everybody thank Dr. Kemble for joining us tonight?
Yeah.
Thank you, Dr. Kemble.
Thank you. Thank you.
Thank you.
Very
great.
important.
Everybody from Facebook thanks you too.
Mahalo.
Thank you so much.
Yeah, Bronwyn wasn't here to say mahalo.
Thanks, everyone. Good night.
Good
Take
night.
care. Good night, everyone.